Good morning. Hi, everybody. So welcome to Project Echo Cardiology. Hopefully this is a fun and enjoyable experience and we can all get some things done that are productive. So I'm just going to start and jump right into it. We got a case from Elizabeth Huser, so thanks so much for submitting that. We appreciate it. And this is actually perfect because what I want to do in this clinic, one of the things that I want to do is have a rapid process so that we can help anybody get PCSK9 inhibitors approved for their patients. And so this is a perfect case. So let me just back up for a second and say that the plan for this clinic is to do a portion of case-based presentations, and that'll be part of the clinic, maybe 30 minutes, and then maybe 10 minutes of EKGs and maybe a 15-minute presentation at the end. And so that'll change with time as the caseload increases and things like that. But that's the general idea for the structure of how we're going to use the hour. So, so let's do it. Perfect. Well, okay, so the talk for today is about supraventricular tachycardia. And again, I'm Ivan Anderson, one of the cardiologists with Renown. So before we get into the weeds with all this business of SVT, I just wanted to review that it's important to be systematic in your read of an EKG, and my general approach is rate, rhythm, axis, intervals, hypertrophy, ischemia. So if you're pretty systematic about that, then you're not going to miss things. And most importantly, I think, is that putting ischemia last will help you to not miss other things, because most people, oftentimes, myself and other practitioners, will look for ischemia first. And of course, that's often why we got the EKG, but maybe not the most important thing. So this is very rudimentary, so I'll apologize, but for everyone, remember an EKG is composed of a P wave, QRS complex, and a T wave. The P wave is atrial contraction, QRS is ventricular depolarization, T wave is ventricular repolarization. There are various segments of the EKG pictured: QRS, ST, QT, PR, which is not pictured. There's an R to R interval, there we go. An R to R interval and a P to P interval.
You got to use the touch.
Oh, I see. Okay. There's an R to R, there we go. R to R interval and a P to P interval, which of course in sinus rhythm will be the same. But we're going to talk about a lot of non-sinus rhythms. And then, of course, many people, we talked about QRS axis. I briefly initiated a discussion about QRS axis. Remember, P waves can change their axis too. And so there's a few things to look at when you're thinking about an EKG. I'm not going to go through this algorithm exhaustively. It's posted on the website. Please reach out. We're happy to go through it. But what we're talking about is supraventricular tachycardia, meaning a narrow QRS tachycardia, and that's a narrow QRS is defined as a QRS duration less than 120 milliseconds. More than 120 milliseconds is going to be consistent with a bundle branch block, which still could be an SVT, or ventricular origin, which of course would then not be an SVT. And by ventricular origin, I mean ventricular tachycardia, ventricular fibrillation, etc. So there's an algorithm, but I'm going to hopefully go through the points of this so that that then makes sense at the end. Okay, so if you look at this EKG, to start off with, it's tachycardic, okay? When you have, it's tachycardic, it's irregular. So if you look at the R to R intervals, you'll notice that these picture calipers are different sizes because the R to R intervals are variable. So this is an irregular rapid tachycardia. So oftentimes when we do heart rate, we'll look at the R to R interval in terms of big boxes. So one big box would be 300 milliseconds, 2 would be 150, 3 is 100, 75, 60, 50, 40, 30, 20, 10, etc. So it's irregular, so you have to count the QRS complexes. 1, 2, 3, I won't belabor it, I already counted them. There's 29. It's a 10-second strip, so you multiply by 6 to get to the rate. That's 174 beats per minute. So this is a rapid atrial fibrillation. It's rapid, it's irregular. There's some repolarization abnormality, potentially consistent with left ventricular hypertrophy or ischemia, so non-specific. So just as I think most people who read EKGs routinely would recognize this as rapid atrial fibrillation. So as a starting out point. Okay, so now this rhythm looks initially like it could be sinus. The rate is bradycardic. Okay, there's 1, 2, 3, 4, 5, 6, 7, 8 QRS complexes times 6 is 48. So it's not a tachycardia in the ventricular rate. And the R to R interval looks regular until you get to this R to R interval, in which case it's a bit shorter. So then if you look a little bit more closely at the EKG, you notice that this T wave seems to have a different duration, a different QT interval than this apparent T wave. Well, that seems a little bit odd. And then if you look at the P wave in standard 2, I'll move my cursor off of there, it's downgoing. So again, the P wave should be upgoing in 2, 3, and AVF. A sinus P wave should be upright in 2, 3, and AVF, the inferior leads. So there's a P wave axis as well. So then you say, okay, well, this is some sort of atrial activity. That may be some, and then you march it, and you see that those actually P waves march. And this is then in ectopic atrial rhythm, almost borderline ectopic atrial tachycardia. The rate of the atria is about 96. So anyways, this is just to highlight if this atrial rate were a little faster, it'd be atrial tachycardia. So, okay. So this is a rapid ventricular rate. I'll just say that it's 150 beats per minute. We're looking at lead V1 only, which maybe could be your rhythm strip or something else. And what is highlighted by all of these black arrows is this little divot here that looks like it could be atrial activity. So you really have to kind of search for the atrial activity when you have supraventricular tachycardia, narrow QRS tachycardia. And thank you kindly. And so the way that you can further differentiate these rhythms, which is in that algorithm that I gave you earlier, is to look at the interval between the preceding QRS complex and the P wave. So this is a short RP tachycardia. A long RP tachycardia would mean that the P wave would be farther towards the next QRS than the last one. So this is a short RP tachycardia at a rate of around 150. There's a classic sort of differential for that. But the other thing to notice is that in terms of nomenclature for the QRS complex, it's so Q wave, R, QR complex, and an R prime. So this is an R prime. This is an R prime. An R prime is a classic finding for atrioventricular nodal reentrant tachycardia, or AVNRT. So that's AVNRT, that R prime, AVNRT. So AVNRT is a micro-reentrant arrhythmia of the atrioventricular node. It's a supraventricular tachycardia with a rate around 150 beats per minute, and it's adenosine sensitive. So adenosine stops very briefly for a few seconds conduction through the AV node. So if the arrhythmia has in its circuit the AV node, then the arrhythmia will be stopped with adenosine. Adenosine, the other thing you should know about adenosine is it's a coronary vasodilator. And so if people have obstructive coronary disease, it's more risky to give. So in the patient with a lot of risk factors, you should, be cautious. So the risk would be that you could have a coronary steal phenomenon. That means, like, let's say you have a big left main lesion, and then you increase the flow down the right coronary artery, then you steal the little bit of flow away from that left main, and then they decompensate, and that turns into a different arrhythmia, like a ventricular arrhythmia, or they code or things like that, which looks bad after you gave adenosine. And so it can happen. It's very unlikely. Related to that, you should give this in probably an emergency or ICU type setting exclusively, because you don't want to have that kind of thing in your clinic. If you do, you would need to make sure you know where your code card is and so on and so forth, that nature.
I think we might have a question. Nicola, do you have a question?
Yeah, please fire away.
Nicola, go ahead. We can hear you.
Okay, so let's just go. So I talked abstractly about the anatomy of this arrhythmia, but let me get into that in a little bit more depth. So this is obviously a Netter picture, and to orient you, the right ventricle is there, the right atrium is here, the inferior vena cava comes here, the tricuspid valve is there, the coronary sinus is there. So I'm going to bring this all together in a second, but the atrioventricular node, this is a very basically similar view, but not so many anatomical structures drawn. The AV node is there, and this micro-reentrant arrhythmia involves a fast pathway and a slow pathway. And so, let's see here. So this is where the AV node would be. AV node, slow pathway, fast pathway. So essentially, you're just going to go around this arrhythmia circuit, and every time you go down, that's going to transmit a pulse to the ventricles and drive that supraventricular arrhythmia, and around and around and around. And so one important point about this arrhythmia is that you can simply ablate one of the pathways and stop the arrhythmia. So you can cure it. You can suppress it with beta blockers, calcium channel blockers, sometimes digoxin. You can acutely treat it with vagal maneuvers such as carotid sinus massage, bearing down, putting your head into a bucket of water, coughing. I often will tell people to blow into a pen and pretend that you're going to blow the back out of the pen, so that really forceful contraction of your abdominal musculature can slow down the conduction of the AV node, and if you slow it just enough, by the time it gets down, for example, the slow pathway, the fast pathway will be refractory, or vice versa, and you can break the arrhythmia that way. So there's some things people can do by themselves, but that is AV and RT. So if you have a narrow, complex supraventricular arrhythmia at a rate of around 150 beats per minute, there's a variety of things. The most common true arrhythmia is AV NRT, and I showed you the pseudo R prime. About half of the time you won't see anything. You'll just see a QRS regularly marching. AV RT involves a bypass tract outside of the AV node, but also the AV node. Atrial fibrillation can regularize and be at a rate of around 150. Atrial flutter with 2-to-1 conduction can cause this similar sort of thing. And of course, sinus tachycardia can be at a rate of around 150. So, okay, so here's a different EKG. And again, if you are counting boxes, one big box is 300 beats per minute, two big boxes is 150 beats per minute. So this ventricular rate is just a little slower than 150 beats per minute. So rate is, maybe 145. Rhythm is what we're getting to. QRS axis is leftward. But if you look at this rhythm, you'll notice some atrial activity there, for example, and here, and here. So if you look in the rhythm strip, it looks like it could just be a sinus tachycardia. But if you look really carefully in the ST segment, there's a little divot there. And so that little divot, look at that. Huh? That little divot looks like it could be atrial activity as well. Can we zoom back out, actually? And so then if you march that, you can see that, in fact, it does march through. And so this is atrial flutter with 2-to-1 conduction. So now the question often is asked to me, well, of course, you can't give adenosine in atrial fibrillation or atrial flutter, right? And the answer is no, you can absolutely do that. It's not dangerous, and it won't resolve the arrhythmia like it will with AV-NRT or, less commonly AV-RT. In other words, it won't bring the rhythm back to sinus. Sometimes people will give adenosine to atrial flutter and see this thing. So what you've done is you've given adenosine, you have this, can't tell what this thing is at all. There's something, but it looks a little sawtoothy here, right? Like atrial flutter, like a typical atrial flutter, but you can't really tell. So you give adenosine and then you slow that R to R interval and you bring out this flutter wave. And that's exactly what happens with atrial fibrillation or flutter when you give adenosine, is that you suss out that fibrillation or flutter wave. And so this is actually a maneuver that cardiologists will do not uncommonly to figure out if that flutter wave is sort of a classic sawtoothy flutter wave like we're seeing here, or from the previous EKG, just to go back a second, sort of more of a, this is not a sawtoothy flutter wave. It's a flutter wave, but it's more, this is more like a left-sided atrial flutter, and this is more like a right-sided atrial flutter, a typical atrial flutter. So I'll go through the anatomy of a typical atrial flutter similarly. But this is what you would expect to see with adenosine and atrial flutter. Fibrillation would be similar, except that your fibrillatory wave wouldn't necessarily be so sawtoothy in general. So, okay, so atrial flutters. Going back to the same sort of meta image of the right atrium, right ventricle, tricuspid valve, IVC. So atrial flutter is a macro-reentrant arrhythmia of the right atrium. So this is what I'm going to show a more clear picture in a second, but just to superimpose them. This is an electroanatomical map with an electrophysiology study of atrial flutter. So the rhythm goes down the right atrial free wall in typical atrial flutter, up the interatrial septum, and down and up and down. So macro-reentrant arrhythmia. So in this electroanatomical map, you map the time closer to your catheter. So this is the start of the arrhythmia, this is later on, and this is the very end. And so that shows you how you map it. But anyways, the idea is the same, that it's a macro-reentrant arrhythmia of the right atrium. And what's important about typical atrial flutter, that sawtoothy pattern that we saw, is that it goes through this isthmus between the tricuspid valve and the IVC called the cavo-tricuspid isthmus. And that is where you can make a simple little ablation line and cure this arrhythmia. Now, granted, they could have fibrillation in addition to it or other things like that, but you can stop their atrial flutter with a simple ablation line. So it's an easy procedure, as opposed to an atrial fibrillation ablation, which is left-sided. You have to puncture through the intraatrial septum and find where the pulmonary veins are coming into the left atrium and do more extensive ablation. There's a bunch that goes into that. So just to stay a little bit out of the weeds, there's a couple easily ablatable arrhythmias that I've gone over here. So that's kind of all that I really wanted to talk about to start with. As far as supraventricular arrhythmias, this is a book that's pretty rudimentary, but nonetheless, I think is an excellent reference. Thayer, the only EKG book you'll ever need. It's the alternative to Dubin, which of course is the bright orange colored book that he wrote for many years for prison. And so another website with a lot of EKG examples is called Harvard Wave Maven. You can just Google Harvard Wave Maven and you'll get that website. And this is a journal, a little bit aged now, from the New England Journal of Medicine, a review article on supraventricular arrhythmias that I think is still very germane and complements, hopefully, this lecture reasonably well, talking about arrhythmia circuits, and refractory periods, and really getting deep into the whole thing. So with that, I'll take questions. So I will say this about it, supraventricular tachycardia, always you can try some vagal maneuvers. What I do is I listen to the carotids bilaterally because there's a chance that you can massage them and cause an embolus. I've seen that one time in thousands of carotid massages where somebody actually had a stroke in the immediate aftermath of a carotid massage. Now, whether that had anything to do with the carotid massage was extremely controversial, but so auscultate it first, make sure there's no bruits. If that works, it's also controversial, but at least you did something. And then you can find that carotid bulb and massage it sort of mid-neck, or, and that sometimes will slow them down, maybe break the arrhythmia, or have them do some vagal maneuvers and other things of that sort. Those things are never going to hurt you with a supraventricular arrhythmia. They may not help you, but they aren't going to hurt you. And then, always get help. And these are some people who can be pre-symptomatic. Their troponins can elevate even in young people, and they probably should be in the emergency setting so that we can do these things like adenosine and so on and so forth. So it's a good person who's very fast in a supraventricular arrhythmia and or symptomatic to send to the ER, or give your cardiologist and clinic on call a ring, and they'll guide you through all that stuff. It's not, if they're not very fast in atrial fibrillation, we'll sometimes manage them as an outpatient and put them on an oral anticoagulant, warfarin, Pradaxa, Eliquis, Xarelto, Edoxaban. One of those oral anticoagulants for a few weeks, especially if we don't know when they went into it, so that then we can pursue a rhythm strategy later if we need to, slow them down if they have blood pressure room. If they don't have blood pressure room, off into digoxin. One thing that's really important about atrial fibrillation, and I'm, again, pretty conservative about this, is that if you're not pretty darn sure when they went into it, there is a 10-fold increase in risk of stroke after either chemical or electrical cardioversion. And so, if you give them amiodarone and chemically cardiovert them, there's still an increased risk. So they need to be able to take anticoagulation if you're going to pursue that strategy. And so in the hospital, I may put them on a heparin drip and make sure they don't drop their crit, and then electrically cardiovert them if I'm sure that they I'm pretty sure that they had acute symptoms at a certain point, and then, keep them in rhythm with some sort of rhythm control agent. And then the selection of that, I would highly, when it comes to rhythm control, I would highly encourage you to elicit the support of cardiology or electrophysiology, because there's a lot of ins and outs, and that starts to get a bit dangerous. And so you want to have a lot of experience with those management strategies before you do that. But
Christina, do you have a question?
Yes, Dr. Anderson.
Yeah.
I'm at a rural hospital and we don't have a cardiologist here.
Yeah.
So sometimes we'll have patients come in with new onset AFib, and sometimes some of my colleagues will transfer the patient out saying, well, maybe cardiology will want to do TEE and cardioversion, at this time. Or like, how do you guys decide when to do like anticoagulation for 3 months and then cardiover, or to do TEE and then cardiover right away?
So first off, I give them anticoagulation for 4 to 6 weeks, because that, it's nice if you do 3 months because it shows somebody, it makes everybody really comfortable, but truly to resolve a left atrial thrombus, if you saw a thrombus in the left atrium or the appendage, and you look at that on TEE, if I see that, then I'll anticoagulate them and bring them back in 4 to 6 weeks and then look again. So 4 to 6 weeks is what I do. And the selection for rhythm control is, so are they symptomatic? So do they feel terribly with it? And I would do that, maybe transfer them, in your case, to get better symptom control, because they just can't walk 50 feet without getting dyspneic when they're in AFib. Or if they're hemodynamically questionable, then I think that's a person where you definitely need to do it. But if their blood pressure is 150 and their heart rate's 110, then I might just put them on a little beta blocker and and an oral anticoagulant, and often I will do this, and then get a Holter on them when they're on the beta blocker and see if I can't just rate control them. If they feel well, their left ventricular ejection fraction is normal, and they have good rate control with a nodal blocker, then that's done for me. Rate and rhythm control is no different, except that, sometimes we think symptomatically it's better. That's my approach. There's a million ways to skin this cat. So I don't think that you're really wrong, even if somebody else tells you that for sure you're wrong in doing that. But those are definitely some hard lines where, you would want to think about other strategies.
Okay.
Symptoms: decreased left ventricular ejection fraction, hemodynamic instability. If they're really unstable, then your choice is made for you, cardiovert, right?
Oh yeah, for sure. That's
But
automatic.
outside of that, it's just borderline. So,
Okay, thank you.
yeah, of course.
I'd like to just add that if you have a prolonged atrial fib or any other tachycardia, that the long-term consequences are cardiomyopathy, tachycardia-induced cardiomyopathy. So rate control is very important.
Yeah, and a tachycardia-induced cardiomyopathy, you would expect to develop in somebody who's at a rapid rate for 4 to 6 weeks. So it doesn't take months or years to get there. And if it has happened acutely, then getting them at least rate controlled and maybe rhythm controlled can bring them back to a normal ejection fraction. We do that all the time, actually. I have a slew of people who show up with an EF of 30 in rapid AFib, just felt crummy for a few weeks, didn't want to come to the doctor, and then we get them back in rhythm, and 6 weeks later, or 3 months later, I'll repeat their echo at 60%. So, yes?
Do you always have to fully anticoagulate somebody before you cardiovert them?
I do, because the risk of stroke after is 10 times higher for 2 weeks. So I want to make sure they can take it, because I don't want to be the cause of their stroke.
Right.
But remember, with the oral anticoagulants, they're working within 2 hours. And so as long as they're anticoagulated after, they're fine. So it's not necessary, you don't have to have that pill on board when you electrically cardiovert them. You know, but you need to get it on before you let them out of your grasps.
So we had a patient recently who was in sinus tachycardia for like days in 130s, asymptomatic.
Yeah.
They wanted to cardiovert him because beta blocker didn't work, digoxin didn't work, any medication would work.
Yeah.
But he also had a head bleed, so we couldn't like anticoagulate him.
So here's my thing. The first question is it really sinus tachycardia? So I would personally probably give that person adenosine just to make sure. If you give them adenosine, you're gonna slow them down. You won't see any atrial activity in between. If they're truly in sinus tach, then there's no risk. There's no risk of thrombus formation of the left atrial appendage. So we don't see, that would be a case of inappropriate sinus tachycardia. And so in inappropriate sinus tachycardia, there's no elevation in stroke risk. We see these typically in young people, and you don't have an arrhythmia circuit such that you have so much decrease in the squeeze of the left atrium where it's functionally not squeezing. Fibrillation, your left atrium is going 450 to 600 times a minute. So it's functionally not ejecting anything out of the appendage. And especially in that low flow appendage, you can form a thrombus because you're, in this little side part of the left atrium. So, but in sinus rhythm, that's not an issue. If you look at the appendage velocity, so on transesophageal echocardiogram, we'll look at the appendage velocity, see how fast blood is coming in and out, and that gives us some surrogate for the risk of a thrombus at the bottom of that thing. And in sinus rhythm, it's always normal appendage velocity. And so the risk really isn't there. So that's non-risky.
Okay.
But I would still, the question is, did you correctly diagnose that arrhythmia? And that's a sort of a philosophical question for all of us, right? You can prove it with an electrophysiology study. If you put catheters in the right atrium, at the AV node, in the left ventricle, right ventricle, put all these catheters in there, and then you can see exactly what's going on. But on a surface EKG, you don't always really know with certainty. And then you can do other things like adenosine to bring it up. So, yeah,
Thank you.
one thing could be done. Again, remember, it's a coronary vasodilator, so you want to just have some idea whether that person is at real high risk for obstructive left main disease, which is the only place where it would probably. But the overlap of people who have, let's say, AVNRT or inappropriate sinus tachycardia and obstructive coronary disease isn't that much. Most people are kind of on one side or the other, thankfully. So,
All right. Thank you so much, everyone, for joining us for the first cardiology clinic. We'll be back on November 9th.
Thanks for your time. Have a great day.
Thank you.